Good evening, everyone, and welcome to the Krina public talk tonight on exercise in medicine, the power of movement during and after cancer treatment. I'm Hannah Ostergaard, and I'm the director of the Cancer Research Institute of Northern Alberta, or as we like to call it, Krina. And I'm also a professor in the Department of Medical Microbiology and Immunology, and I am a cancer immunologist, so I work on cancer in the immune system. Before I begin, I'd like to acknowledge that the University of Alberta, its buildings, its labs, and research stations are primarily located on the territory of the Nihiyo, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, and Anishinaabe lands that are now known as part of Treaties 6, 7, and 8, and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. Before we get started tonight, I'd like to say a few words about what Krina is. So we're a research institute associated with the University of Alberta. We have about 170 faculty members who are members of Krina. And our members span essentially the whole campus. We have members from engineering, science, nursing, biochemistry, and oncology over at the Cross Cancer Institute. So it's a multi-pillared, multidisciplinary institute. Our institute is focused on 4 major things. So we're looking at improving cancer outcomes through research, and we do this through trying to understand the biology of cancer. We're using novel methods and to detect cancer and identifying vulnerabilities in cancer to treat cancer. And we're also doing we have a number of researchers who are doing work in helping people live better with cancer and after cancer, and that's part of what you'll be seeing tonight as well. I'd like to mention that we also receive no support from the university. We run completely off of donations, and I know we have a couple of donors here with us tonight. And for your support, I am really grateful because we couldn't do the work that we do without your support. Through these donations, we're able to do a number of things. So we provide bridge grants so that people can initiate new directions of research or initiate collaborations. We provide bridge grants, and we also have support for our graduate students. Graduate students are the people who actually do the research. People like me, we sit in the office and write grants and get the money to do research, but the graduate students are so important to support. And I'm so pleased that we are just able now to provide about $400,000 in support for graduate students. We should be announcing this shortly, which is, again, thanks to the support from people like you. So now that you know a little bit about our institute, I'll introduce the first speaker for this evening. So Dr. Carrie Cornier is a professor in the Faculty of Kinesiology, Sport, and Recreation and director of the Exercise Oncology Research Laboratory. His research focuses on the role of exercise after a cancer diagnosis, including how exercise may help cancer patients prepare for treatments, tolerate and respond to treatments, recover after treatments, and improve long-term survival. He's also recently been named, or in 2023 was named an officer in the Order of Canada, which recognizes his incredible work that he has done. And many of you may have seen in the news, he had some work that made a big splash. I think he'll be talking a bit about that. It was in the news all over the place and made a huge impact. And so Dr. Cornier, thank you for coming, and we ask you to give your talk.
Thank you, Hannah, for that invitation. And thank you, everyone, for coming today. And in thinking about what I wanted to talk about today in a short time of 25 minutes, I thought I should really focus on this new evidence that we're generating related to exercise as a treatment for cancer. As Hannah just talked about, living with cancer has really been the focus of most exercise researchers, quality of life, symptom management. But more recently, we're looking at exercise not as a quality of life intervention, but like an immunotherapy or a chemotherapy. Can it actually treat the cancer? And so that's going to be the focus of my talk this evening. So for those you know a little bit about exercise oncology, exercise now is well established as a supportive care intervention. And what I mean by a supportive care intervention is really an intervention that helps patients feel better and function better. Improvements in things like health-related fitness, so cardiovascular fitness, muscular strength, flexibility, balance, and body composition as well. Fat loss, improving lean body mass. Helps with symptom management, particularly things like fatigue, lymphedema, and other symptoms. Improvements in psychosocial functioning, anxiety and depression, and also improvements in things like sleep quality. So overall, exercise has been shown to be a very good quality of life intervention. And there's now hundreds of studies that have documented these types of quality of life benefits. And it's just demonstrated these benefits across all disease stages. So most of the research is focused on early stage disease, but more recently, we've looked at patients with advanced cancer. And we've done these studies in almost all types of cancer: breast, prostate, colorectal, lung, kidney, bladder, head and neck cancer, all the various cancers. But perhaps a few we haven't studied yet, less evidence in cancers like brain cancer, pancreatic cancer, and a few others. And we look at these interventions before, during, and after treatment. So helping patients prepare for treatments. What's the role of exercise during treatments like chemotherapy, helping them cope with those treatments and recover afterwards. We've looked at all sorts of different exercise prescriptions. We've studied the classic aerobic exercise interventions, looked at weight training interventions, yoga, high intensity, moderate intensity. We've studied walking programs, so all sorts of different exercise prescriptions and different ways of delivering these exercise programs. Most of the research has been supervised. We bring them in, supervise the exercise interventions. But now we're also doing home-based and of course, virtual or digital delivery of these programs. Can we deliver them through digital means and still get the same sort of outcomes? So all this evidence has been generated over the last couple of decades, and this is what's really resulted in this research getting into practice. So we now have guidelines for exercise for cancer patients from exercise science bodies, but also from different cancer societies like the American Cancer Society, the Canadian Cancer Society. But our biggest win, if you will, is the guidelines that came out from ASCO. So these came out only recently, 2022. ASCO is the American Society of Clinical Oncology, and this is the group of the oncologists, so all the doctors who treat cancer. And they independently evaluated all the evidence for diet, for weight management, and for exercise. And they only came up with one recommendation where the evidence was sufficient and enough that they can now say we should be doing this for our patients. And that recommendation was for exercise. So you can see here, the recommendation says oncology providers should recommend aerobic and resistance exercise during active treatment with curative intent to mitigate the side effects of cancer treatment. And they list some of the key improvements that were documented in the literature: reduce fatigue, improve cardiovascular fitness, physical functioning, anxiety, depression, and so on, with a very low risk of adverse events. So the benefits of exercise in cancer patients far outweigh any of these risks. But there's a couple key things here in this recommendation. One, it's for curative intent. So they weren't looking at patients with advanced cancer, although that research has progressed over the last couple of years. And they very specifically say to mitigate the side effects of cancer treatment. In other words, that quality of life or supportive care role. No indication whatsoever that exercise can treat cancer. In fact, they concluded that it's inconclusive whether or not exercise plays any role in treating cancer. So that's where we are with the current evidence. So we can say right now that exercise has not been established as a cancer treatment for any type of cancer in any clinical oncology setting. So all the guidelines you hear about that recommend exercise are always for these quality of life benefits. But there's a lot of interest in testing exercise as a potential cancer treatment in various clinical settings like active surveillance, the neoadjuvant setting, and adjuvant settings. And this is based on preliminary evidence from animal studies, these preclinical models where we can look at exercise in mice with cancer and see if the cancer grows more slowly or more quickly. We've done a lot of observational studies looking at associations between patients who report high exercise versus low exercise. Do they tend to live longer? All positive findings. And some small exploratory studies looking at the mechanisms or things that are related to cancer moving in the right direction when we do exercise. So this is what I want to focus on tonight, to see whether or not exercise can serve as a cancer treatment in addition to these very important quality of life benefits. So one of the settings I mentioned was active surveillance. So this is the generally only used in prostate cancer, although they're starting to look at it in other cancer patients as well. But this is the idea of being diagnosed with a very small, low-grade tumor that is so inconsequential that we don't even want to treat it right away. We just want to monitor it for a while and see whether or not it progresses and gets any worse. So these men are diagnosed with prostate cancer. They're not giving any treatments. And they're always keen to know, what can I do to help with this prostate cancer that I have? So it's a really interesting setting to look at the role of these lifestyle interventions, including exercise. So this is a study done by a former PhD student, Dongwoo Kang, who's now a physician at the Fred Hutch Cancer Center in Seattle. And he recruited 52 men with prostate cancer who are on active surveillance and put them in two different groups. One got 12 weeks of supervised high-intensity interval training 3 times per week for the 12 weeks, and the other got no exercise, just usual care, and followed them over the 12 weeks, taking blood samples and looking at changes in some of these biomarkers. So what he found was very suggestive. So some of you will know that PSA, or prostate-specific antigen, is a marker that might indicate some higher levels of prostate cancer in the prostate. And he showed in this study that the exercise group had lower PSA levels compared to the usual care group. They also had lower prostate-specific antigen velocity, so how quickly the PSA was increasing, and a slower PSA doubling time. So how long does it take the PSA to double over time? So all these changes, very positive and suggestive that exercise might be having some impact on the prostate cancer. He then also looked at a cell line of prostate cancers. And what we can do is we can put these prostate cancer cells in a petri dish, and then we can expose it to the blood of the men who have exercised versus the blood of the men who didn't exercise. We can look at what happens to those prostate cancer cells in the petri dish. And what these data here show is that the prostate cancer cells exposed to the blood of the men who exercise grew much more slowly. So it slowed down the growth of these prostate cancer cells compared to the men who didn't exercise. So this suggests there's something in the blood or serum of these men who exercise that has anti-cancer properties. And we think it's things like insulin levels and IGF, insulin-like growth factor levels. We also think it's related to immune function. So things like natural killer cells, macrophages, and T cells that are all increased by exercise with improved activity. And also anti-inflammatory mechanisms, things like C-reactive protein, TNF-alpha, and interleukin-6. So there's all sorts of these biological changes that exercise produces that line up very nicely with some of these anti-cancer properties. So very suggestive of benefit. This study got a little bit of media attention, and I think the headline here is fairly accurate. It's asking the question, can working out slow prostate cancer progression? So we don't think exercise by itself is going to cure prostate cancer. It's not going to eliminate it completely. This is what we see in the mouse models. Same thing. We can slow the growth of the cancer, but we don't sort of cure it or eliminate it. But slowing down prostate cancer progression might be very meaningful in the active surveillance setting, because that means these men can stay on active surveillance longer, not have to go on to get the radical treatments and experience some of the side effects. So very promising study, but very small, 52 patients randomized in this study. The other area that we're looking at in lots of interesting research is what we call the neoadjuvant setting. So this is where patients have an existing tumor, and instead of cutting it out right away, we leave it there, but we treat it with chemotherapy or radiation therapy. And the goal is to try and shrink that tumor or eliminate it completely prior to getting surgery later on. So this neoadjuvant treatment is fairly popular. So in rectal cancer, the way this neoadjuvant treatment happens is patients get diagnosed with a rectal cancer, and they start off with a combination of chemoradiation therapy. So they get 5 to 6 weeks of radiation therapy, and they get a little bit of chemotherapy with it. And the goal is to shrink that tumor so they can do an easier resection or surgical removal of the tumor, or to eliminate it altogether to do even a more minor surgery. So they get that for 5 to 6 weeks. They get a break for 6 to 8 weeks before they go on to the surgery. And the tumor typically continues to shrink during that break. So we looked at an intervention, and it was 36 patients. So again, a very small trial where we did a supervised exercise program during that 5 to 6 weeks of chemoradiation therapy, and then a home-based program during the break. So patients either did the exercise program or no exercise. And then we followed them up at the time of surgery to see what happened to the tumors based on the group that exercised versus didn't. Much to our pleasant surprise, not only did we see a signal of a potential effect, but we saw a statistically significant effect. So you can see here that the AET, the aerobic exercise training group, 10 out of 18, or about 55% of patients had a complete response to the chemoradiation. So that means the tumors are gone. There's no tumor left at the end of the treatment. Compared to 3 out of 17 in the usual care group, the group that didn't exercise. So about 15% of those patients had this complete response, which is the best response you can get to the treatment. And there's some likely mechanisms here that we've seen in some of the preclinical models. And exercise improves tumor vasculature. It improves the blood vessels in the tumor and gets better quality and more of these blood vessels. And we think this potentially helps with the delivery of these chemotherapy drugs to the tumor. It also better oxygenates the tumor, which makes them more sensitive to radiation therapy. So these improvements in kind of the tumor itself from exercise may allow these other treatments to work more effectively. This study also got a little bit of attention, and even more of a provocative headline suggesting patients with rectal cancer who exercise while receiving radiation therapy more likely to have tumors disappear. So again, a very small study, so it's not large enough for it to be definitive, but very suggestive of a potential benefit. And here we see that integrating exercise with other treatments may result in more cures. So exercise by itself won't cure cancer, but when you integrate it with other cancer treatments, it's possible that it produces more cures. The big study that Hannah mentioned is just published a few months ago. And this was the first what we call large-scale definitive phase 3 trial trying to find out, does exercise improve survival? Is exercise a treatment for cancer? So this study meets the same rigorous standards for any of the drugs that you guys receive. So if there's a new immunotherapy, it's been through a large-scale phase 3 trial. If there's newer chemotherapy or radiation therapy, it's been through this trial. So we subjected exercise to the same rigorous test of these drugs. So this was a trial that was organized by the Canadian Cancer Trials Group. It was funded by the Canadian Cancer Society. We had over 55 centers in 6 different countries around the world contribute to this study. So it was a very big international project. And right here in Edmonton, we recruited more patients to the study than any other center around the world. Over 80 patients from Edmonton were put on this particular study. So this is the basic design of the study we call the challenge trial. So the eligibility for this study was resected, so that means surgery, stage 3 or high-risk stage 2 colon cancer. So these patients went in for surgery and had their stage 3 or high-risk stage 2 cancer surgically removed. And then they went on to complete 6 months 3 to 6 months of chemotherapy. And we recruited them just after chemotherapy. So they were done the surgery, completed the chemotherapy, and that's when we recruited them to this study. Because these patients with this stage 3 and high-risk stage 2 colon cancer have about a 20 to 30% chance of the cancer coming back. So the cancer recurring and spreading elsewhere. So it's still very high risk despite getting the surgery and the chemotherapy. They also had to be doing less than 150 minutes of exercise per week, so we didn't want them already meeting the exercise guidelines. And they had to be able to walk on a treadmill or just a regular surface for 6 minutes. So they had to be at least ambulatory and functional because we were going to try and increase their exercise levels quite a bit. Baseline testing we did on stuff like their fitness levels, how they were functioning, various quality of life scales, health economic analysis, and we also took blood samples to look at some of these mechanisms that might be changing. We recruited 889 patients. So this is a very large-scale phase 3 trial, large enough to give us a definitive answer to this question. And it's the largest study in exercise oncology. We randomized 444 patients to the health education materials, which we deemed to be standard of care. So these patients were recommended, here's the guidelines. Yes, you should exercise. Good luck. And off you go. And that's kind of what we give most patients right now when we tell them to exercise. And then we compared it to our intervention, which was a structured exercise program with support. So this was a 3-year intervention, but in addition to the health education materials, they received 3 years of support that I'll talk about in a moment. So the big issue for this trial, you can see at the very end, is survival endpoints. This is the first study in the world of exercise where the primary endpoint was survival. So we looked at disease-free survival, which includes whether or not they had a recurrence, whether a second cancer happens, or whether they die from any cause. And we look at overall survival, which is death from any cause. So these are the primary endpoints you would see in an immunotherapy trial or a chemotherapy trial. And we followed them up for a median of 8-year follow-up, with many of the patients being followed up for 10 years. So these are the health education materials we provided, just given to each of the patients in the health education group that instructed them on exercise and how much they should exercise. And then the intervention group met with an exercise specialist every 2 weeks for the first 6 months, every 2 weeks for the second 6 months, and then once a month for years 2 and 3. So we kept the intervention going for 3 years to try and make sure we could keep them exercising. And during the first 6 months, they were mandatory in-person sessions where they also got a supervised exercise session. In the second 6 months and the last 2 years, they could do it remotely if they wanted to, or they could continue in-person counseling sessions. And if so, they also got a supervised exercise session. And this whole program, the key to this program is it's based on behavioral science. So there's a science between behavior change. It's not just handing somebody a material, shaking their hand and saying, good luck with your exercise program. All right, it doesn't work very well, as many of you will know. So they've got a full behavior, evidence-based science program on how to increase physical activity and maintain it over an extended period of time. And so what we're able to show is that the exercise group there in orange compared to the health education group did increase their exercise much more. And not only increasing it much more, maintaining that over the entire 3 years. So that was critical. So the exercise intervention group did more exercise than the health education group for the entire 3 years of the intervention. So this is very effective in terms of behavior change. We also improved fitness. So not only were they exercising more, they were fitter for the entire 3 years of the intervention. So this is in itself is a major achievement in these types of trials, being able to develop and deliver a lifestyle intervention that results in a substantial behavior change maintained for 3 years. We also showed improvements in 6-minute walk and the physical functioning subscale, which is patient reporting how they're functioning. And you can see through the entire intervention, the exercise group reported that they were functioning better than those in the health education group. But the big news was the improvement in disease-free survival. So as I said, this is whether or not the cancer comes back, you get a second cancer, or you die. And the hazard ratio here of 0.72 suggests that the group that got the supervised structured exercise program was 28% less likely to have a recurrence or second cancer over this extended follow-up over 10 years. And you can see here at 60 months or 5 years, 80.3% of the patients in the exercise group were alive without a recurrence and without a second cancer, compared to 74% in the health education group. Even more impressive were the improvements in overall survival. So this is simply death, mortality, the ultimate outcome in all of these clinical cancer trials. And you can see here a hazard ratio of 0.63. So this means the group that got the structured exercise program were 37% less likely to die during 10-year follow-up compared to those who didn't. And you can look at our 8-year overall survival at 96 months. All right, at 96 months, 8 years later, 90% of patients in the exercise group were alive, compared to 83% of patients in the health education group. So a 7% absolute difference in the number of patients who are alive from the exercise group compared to the health education group. So put that in context. How good is that? So we can compare the challenge trial results to all the drugs that we currently fund. And so adjuvant exercise, that's what we tested in colon. We showed 7% absolute gain in overall survival at 8 years. FOLFOX, which is the chemotherapy we give these cancer patients, has a 5% absolute survival difference at 10 years. And you can see some of these other drugs in non-small cell lung cancer, 8, 10%, 5% in breast cancer, 5% triple negative breast cancer. So you can see from these data that exercise is as good as, if not better, than many of the current drugs we give to these patients. And these drugs cost tens of thousands of dollars, if not hundreds of thousands of dollars in some of these cases. So this slide blew a lot of people's mind at the ASCO conference when we presented these data. And this was picked up by social media and sent out everywhere. Not only is exercise treating cancer like these other ones, it's treating it just as well, if not better. So this trial, needless to say, got a lot of media attention around the world, picked up by all the major news outlets. Many of the headlines were very positive and very exciting. A couple were a little bit more provocative. We had a headline like exercise rivals drugs in bid to stop cancer returning after treatment. And another headline you can see there, why exercise is as good as chemo for cancer patients. This got a little bit misinterpreted in the literature. Some people were suggesting you should exercise instead of getting your chemo, that you don't need your chemo. So we had to clarify that we're saying this is exercise after you complete your chemo. But the magnitude of the benefit is as good as or better than that chemo you just completed a few months earlier. So the take-home message, don't take cancer lying down. There's lots of benefits that we've talked about, and it's possible that it may be a treatment for some cancers. Giving you a few of the general exercise principles to follow if you're interested in exercise. First of all, the recommendation is just to avoid inactivity. Sedentary behavior may be bad, so sitting around all day doing very little movement may not be good. We also note some exercise is better than none. I'll show you the actual recommendations, but even less than the recommendations may be beneficial. And more exercise is generally better. So like many interventions, many drugs, there is a dose-response benefit. The more exercise you do, the more beneficial it is. Starting easy and progressing slowly can be very important, especially for patients who haven't exercised before and are trying to start during treatments. And ultimately, exercise should be individualized based on type of cancer, stage of disease, the treatments, side effects, and preferences. And I know Margie McNeely will talk a little bit about that with her program. So the recommendations are 150 minutes per week of moderate intensity aerobic exercise, which usually is the equivalent of brisk walking. If you're brisk walking, that will get you into the moderate intensity zone. It doesn't seem to matter how you get that 150 minutes. So you can do 3 days per week for 50 minutes, 5 days per week for 30 minutes, and even 2 days a week for 75 minutes. We sometimes refer to that group as the weekend warriors. You just do all your exercise on Saturday and Sunday. But as long as you get to that 150 minutes, it seems to be beneficial. If you're interested in able to do more vigorous intensity exercise, then even less, 75 minutes will give you similar types of benefits. So that's jogging 3 times per week for 25 minutes. Strength training is also very important, and they do recommend 2 to 3 days per week of these strength exercises. And then adding what we call activity supplements or activity snacks throughout the day. So just getting up and moving around, taking the stairs instead of the elevator, parking at the far end of the parking lot and walking into the store. So just different ways of getting smaller amounts of activity can also be beneficial. So in summary, exercise is safe and feasible for most cancer patients, and exercise improves fitness, function, and quality of life for most of these patients as well. Exercise may be a treatment for some cancers. So this is the newer research that we've been doing, and we would probably say exercise is a treatment for stage 3 colon cancer and high-risk stage 2 colon cancer. There are some small risks with exercise, but these can be mitigated with a personalized prescription. And we do think clinical practice may be changing. Challenge is really reverberating about throughout the country and actually around the world. Getting emails from all different countries around the world saying, we're putting this into practice, we're changing our practice because of these challenge trial results. So I think you're going to see over the coming months and years, even within Canada, this is going to start to be incorporated into cancer care in a more serious and meaningful way, beyond just sort of a recommendation that cancer patients exercise. And there's now many resources available to help cancer patients exercise and follow the guidelines. Thank you for your time.
Okay, so our next speaker is Dr. Margie McNeely. She's a professor in the departments of physical therapy and oncology at the University of Alberta in a jointly funded position with Cancer Care Alberta. She is the director of the Cancer Rehabilitation Research Clinic at the University of Alberta. Her primary interests involved examining physical therapy and exercise interventions for cancer-related impairments, including shoulder dysfunction, peripheral nerve injuries, and lymphedema. And we're so grateful that she's willing to talk to you tonight about her research.
Great. All right. So as Hannah said, my 2 homes, the Cross Cancer Institute and the University of Alberta. So I will be speaking about exercise as a key component of interdisciplinary cancer rehabilitation. I have no disclosures, financial or otherwise. So in this presentation, I'm going to share with you insights from the Alberta Cancer Exercise Study, where we've offered ACE, who and how many people have taken part in this study, and the main findings in terms of implementation, fitness outcomes, and safety. ACE has also served as a foundation for several subsequent studies in my cancer research clinic. And so I'm just going to talk about 2 tonight. One will be the DREAM trial, which was for breast cancer-related lymphedema. And the second one is a study that's currently ongoing, which we call Control for Life, which is a combined pelvic health and exercise intervention for men with prostate cancer. So the Alberta Cancer Exercise Program is a hybrid effectiveness implementation study. Exercise is increasingly recognized as a cornerstone of cancer recovery and long-term wellness. And as you heard from Dr. Kernier, we know that exercise works. The question is, how do we make it accessible, safe, and sustainable for people with cancer in the real world or in the clinical setting? And so we designed and delivered ACE to actually answer that question. Interestingly, we started work in terms of implementation of exercise over 10 years ago. So well ahead of the game. And that was largely due to the research evidence that was being generated here in Alberta, largely by Dr. Kernier, but also investigators from the University of Calgary, Dr. Christine Friedenreich, Dr. Kulos Reed, as well as Dr. Jeff Valance from Athabasca University. So some really good researchers in our province. So about ACE. So as I said, a hybrid effectiveness implementation study. So we were looking at two components. How do we implement exercise for patients with cancer, but also to evaluate, is our exercise program beneficial for those individuals who take part? When we looked at the research evidence at the time in implementation of exercise programs, which were starting in some jurisdictions around the world, what we found was they reported the outcomes in terms of implementation, but not necessarily the outcomes in terms of the effectiveness of the exercise intervention. And we felt that was really important to know, are we going to get the same benefits that we see in these randomized controlled trials that have been conducted? It was a 5-year implementation study funded through the Alberta Innovates and the Alberta Cancer Foundation. It took us 6 years to complete, and that was largely due to the COVID-19 pandemic that disrupted our programming. ACE was patient-centered and evidence-informed. So before we even started ACE, we brought patients in, we did focus groups, we asked them, if we were going to offer this program, what would you like it to look like? And we used a lot of what we heard from the patients in the design and delivery of the ACE program. It is a clinic to community model of care, meaning that we identify the patients through the cancer system or the healthcare system, but we deliver the program outside of the healthcare system in the community. This is our ACE research team, so you can see me over to the left. So the University of Alberta was actually the lead site for the hybrid effectiveness implementation study. So we held the grant funds and the database. Dr. Chris Seller was our project coordinator overseeing the program around the province. Co-lead for the ACE was Dr. Kulos Reed, so she and her team with Tanya Williamson, who is the research coordinator and clinical exercise physiology, ran the South Hub. So we had two kind of centers running the ACE program, one in the north and one in the south. I will mention too that Dr. Kulos Reed and her team are actually leading a national trial where they were taking a program very similar to ACE and implementing it for individuals living in rural and remote locations across the country. So there are some key features of the ACE program which we feel are really important and help to make the program effective. The first one, and we heard this from both our oncology teams as well as our patients, was the need for screening and triage. They wanted to make sure that patients were safe to take part in exercise, especially if the program was being delivered in the community location. The other part that we do with ACE is we support their referral to that location where they are going to exercise. Patients told us they didn't want to exercise in a hospital setting. They wanted to exercise in the community in a location that was closer to home with no parking fees. So they did not want to be at the hospital. And the third key component, I think, with ACE was we heard this again from the patients, they wanted the person teaching the exercise program or the class to understand about cancer. So taking this premise, we knew that the exercise specialists working in the community know about exercise. So what we did was teach them about cancer. So we have a program that's offered through the University of Calgary, through Dr. Kulos Reed's clinic, where they can take the training to learn more about cancer. So all of our ACE exercise specialists who deliver the program have taken this training. We also provide support to those exercise specialists when they're delivering the program in the community through our 2 hub teams. So our clinical exercise physiologists are available to support them either in person or virtually. And the third thing we support our exercise specialists with is the communication with the oncology teams. So if there are any issues with an individual in a class, they can connect with us. We can connect them with the oncology team to help facilitate any issues. So we've had big numbers take part in the ACE program since 2017, over 3,000 individuals with cancer from across Alberta. 2,570 took part in the effectiveness implementation study, and we're over 600 participants in what we call the ACE sustainability study, so it's still going on as a study. However, the grant funding has ended and the program is funded by donations, but we're continuing to offer the program. Prior to COVID, we had 18 sites that were offering in-person programming across Alberta. After COVID, we've had 14 of those that have restored their services in person. Obviously, during COVID, we offered programs virtually, and we've continued to do that after the pandemic. And we usually have about 3 to 5 virtual programs running each session for our new participants. And then you can see with the map on the right-hand side, there's 2 stars. Those are 2 hub sites at the University of Alberta and the University of Calgary. So in the north, we do service all the programs or support the programs in Edmonton, Red Deer, Grand Prairie, and Fort McMurray. And in Calgary, they were supporting the programs in that city, as well as Lethbridge and Medicine Hat. And then because we were also doing the Excel study, Fort McMurray and Medicine Hat after COVID actually moved to our Excel study. So we actually offer the programs now what we call the cancer corridor. So Lethbridge, Calgary, Red Deer, Edmonton, and Grand Prairie. With ACE, we also have a screening, as we said, screening process that they have to go through. So this looks like a very, very busy slide, but there are 4 steps in our screening. We have a pre-screen, which we started after the first year of our ACE program. So I'll talk about that in a little bit. But that's for our high-risk cancers and our individuals where the cancer is spread or is metastatic, where we go actually back to the oncologist and we verify that this person is actually appropriate to even consider for our ACE program. Then we have a cancer intake where we ask the individual about their cancer, what type they have, what treatments they may be undergoing or have undergone, any symptoms they may have related to their cancer or impairments related to their cancer treatment, and their current and past physical activity behavior. Then we also ask them about other conditions they may have or comorbidities. And all participants are required to complete a physical activity readiness questionnaire so that we will understand what other risks they may have related to exercise due to these other conditions besides cancer. And then they finish with a fitness test. So prior to that, they will undergo an interview with a clinical exercise physiologist who reviews all of their forms, their intake forms, their symptoms, their impairments, just to ensure that we have all the information that we need. And at that, then they will book their fitness test where we will do vitals, we'll do our fitness testing, and really here what we're trying to look at is how is that person moving, what's their mobility like, and what's their exercise tolerance. So sometimes we can see all the forms, but we see the person in front of us doing these fitness tests, we learn a lot about their abilities. I'll have to say with our screening, it's very involved, but about 90% of the people move right through those steps and they're just fine and we send them out to the community location. About 10%, we're kind of having to go back and forth either with the oncology team or the primary care physician to kind of sort out some issues before we decide whether they should come into the program or not. So lots of different options, and we try to get people placed in a location or service that's going to help them in terms of exercise. So we do have different class types. So over on the left-hand side is our circuit training class, and this is the most common. So most of the community centers opt to offer this type of programming. So this is up to the center itself, what kind of programming they want to do. So you can see with the picture on the left, it's a group exercise class. So it's led by an instructor and it's a circuit training program. So either the patients move around in a circuit or they have their own location in the room with their chair and their equipment, and they just follow the lead of the instructor. The second type of programming that we have, which is only in the north, is what we call group personal training. So this would be where that individual goes into the fitness center of the location rather than a studio. And they may start with some aerobic exercise training. So they may do a treadmill or a bike or elliptical. And then they follow their own program in terms of strength training, flexibility, and balance training. And of course, supervised by one of our exercise specialists. And then the third option, again, which we introduced during COVID-19, was virtual, where individuals will join a group class from their home. So some results. So in this figure provides some insight into the individuals taking part in ACE. So you can see the largest group represented by that pink slice of the pie or circle is the breast cancer group, accounting for 45%. The second most common group was the hematological or blood cancer group. So that's our leukemias, lymphomas, multiple myelomas, followed by our prostate, colorectal, and head and neck cancers. In terms of demographics, the average age just under 58 years of age with a range of 17 to 91 years, and just over 71% of participants are actually working age non-retired Albertans, which means that we're kind of getting about a 9 to 10 year younger demographic than the average in Alberta. About 70% are female, and just under half are undergoing cancer treatment at the time that they took part in the ACE trial. In terms of cancer stages, here again, we were really surprised to see this, but about 27% of individuals coming into the ACE program have advanced stage cancer at that time. So they're still undergoing treatment. We were not expecting to have big numbers like this. And at that time, when we started ACE, we didn't have a whole lot of evidence to kind of guide practice in terms of this group. So we've learned a lot by offering the ACE program to all cancers and all stages. We also see differences between the North and the South. So a lot of times I'm asked to, to share results by the different locations. And I always say, well, we're kind of talking about apples and oranges, or maybe apples and oranges and bananas. It's really hard to compare the sites a lot of the times because the types of cancers are a little bit different between the sites. So even though breast cancer is by far the largest group and across all of our sites, in Calgary, we tend to see more females joining the ACE program, more breast cancer, more gynecological cancers, more blood cancers as well, but tends to be leukemias and lymphomas. Whereas in the North, we tend to see more head and neck cancers, more digestive cancers, more prostate cancers, and more neurological or brain tumor patients. So not surprisingly, we also see a different profile in what we call our high-risk group. So this isn't necessarily high risk in terms of their cancer treatments. This is high risk in terms of the complexity around the exercise prescription. So in the North, we tend to see more complex cancers than we see in the South or at the other locations. And as well, slightly more males in the North as well. So you can imagine when we have these differences, it's really hard to compare the findings because they are interrelated with the type of cancer, the risk status of that individual, and their biological sex. In terms of cancer-related effects and impairments, not surprising, the number one reason that individuals, or the symptom that they report, and often the reason that they're coming into the ACE program, is due to cancer-related fatigue, so 76%. Muscle and joint aches and pains was number 2. And again, this is related to their cancer treatment, not related to other things. The third one, chemotherapy-induced peripheral neuropathy. So that's where the individuals get the numbness and tingling in their hands and their feet from the chemotherapy treatment that they've had. And you can see it's almost half of the people coming in report this symptom. In terms of comorbidities, arthritis, number 1. Again, probably not surprising given the average age of individuals coming into the program, but something we really have to work around when we're prescribing exercise. It's the number 1 thing in most of the classes. We're dealing with joint issues, knees and hips and shoulders and backs, and trying to work around that in terms of the exercise prescription. This data is on physical activity behavior, and Dr. Kearney talked a little bit about that as well in his. And what's really interesting here is and I get this question all the time, well, the people taking part in ACE must be really active anyway. Nope, they're not. And 46.6% reported 0 minutes, 0, of moderate or vigorous intensity exercise. So very sedentary group. And even within the active and insufficiently active, that may be where people may self-report a little bit differently. But the zeros, very sedentary. So I get asked as well, why did you allow people who were active to come into the ACE program? Well, what we find with the individuals who are active, most of them want some kind of support in terms of exercise. So they may be those individuals where walking 100 or 150 minutes per week of physical activity, that's our minimum guideline standard. And these individuals may be much more active or may have been much more active than that prior to their cancer treatment, wanting to return to things like sport, or they may have an occupation that is just involves more physical activity, more lifting, those kind of tasks. And they know they need to get fitter, they need to have better endurance, and they need to be stronger to get back to work. Implementation outcomes, and I always say this is the data I'm always the most proud of in terms of the ACE program. Completion rates. So this is the number of people who came in, did all their baseline testing, took part in the exercise program, and then came back for their 12-week physical fitness test and completed all their outcome measures associated with the study, ranging from 89 to 91%. So no statistical significant difference between our sites. So really good completion rates across the sites. Attendance rates, again, very good, from 73 to 80%. Our target here was to be higher than 70%, and so we were able to exceed that. We also had some key fitness outcomes that we were looking at with this study, and again, with ACE, prior to starting the trial, we set targets, so things that we wanted to achieve in terms of these outcomes, and those were set based on two things. Number one, the research evidence and what kind of changes we were seeing in some of the randomized controlled trials, but also a change that was enough that would make a difference to that individual in terms of their day-to-day activities. So the first test over to the left-hand side, the 6-minute walk test. So individuals will walk as far as they can, either on a track or in a hallway back and forth, and cover as much distance as they can in 6 minutes. And our target here was 30 meters, and we exceeded it. So the average was 39.6 meters across all the participants who took part. The second test, nice little test for lower body strength and endurance, a sit-to-stand test. So here we'd ask individuals to go from a seated position to a standing position as many times as they could in 30 seconds. And the goal here is we know we need to make a change of 2 to have a significant effect on their function. And so again, exceeding that target with an average of 2.8. Symptoms and quality of life. And here's where when we put all the data together and looked at all the participant results, we actually did get statistically significant findings for all of our outcomes, but we have a huge sample size. So it wasn't that hard. What we didn't meet were some of those targets that we had for these outcomes. So including fatigue, including our functioning and quality of life. So we had to look at the data a little bit more. And what actually we found was where the difference happened was the individuals on chemotherapy compared to those who were receiving other cancer treatments but not chemotherapy or were post-treatment. And so when we separated the data that way, we could see that we actually achieved a lot of those targets for that group that was not undergoing chemotherapy. So we reached those targets. Having said that, and I think a lot of people would agree with me on this, undergoing chemotherapy, we often see that people's symptoms get worse. Their functioning gets worse. Their quality of life gets worse. So even if we're making a small change or keeping it stable, I think that's a beneficial effect. In terms of safety, we did have 6 serious health events or 6 serious adverse events, 5 of which happened in the first year of the ACE program. So again, going back to our screening, we instituted that first step, the pre-screen, because of these events. Our goal was to have an adverse event rate, serious adverse event rate of less than 1%. So we did achieve that. Having said that, we don't like having adverse events. We did not want to have adverse events. So looking at these events, 4 of them involve participants with advanced stage or high-risk cancers, and all 6 were on active cancer treatment at the time. Some of the examples of what happened, we had cardiac events, 1 neurological event, and 1 fall, 2 events that were unrelated to exercise. So the fall actually happened in the community site when the person was coming in, so hadn't even started the exercise program, had a fall, hit her head, we had to take her to the hospital. The second one was an individual who came into one of our sites, was not feeling well when he came in, The exercise specialist was worried about him, took him to the side, talked to him and said, I don't think you should exercise today. They decided to call the caregiver. Caregiver wasn't able to get to the site in a timely way. We decided to call an ambulance and they actually went to the hospital. All participants recovered, so without any adverse events. So we felt that our safety procedures as well that we had in place were ready for these kind of events because we had anticipated that they would happen. So again, we reviewed our screening and our monitoring to try to improve our outcomes. So as I said, 1 since our first 5 in our first year, 1 since then. So moving on, kind of not the end of the story, but I'll run through this really quickly. Building off of ACE, now that we started to see ACE and these great benefits from the program, we've sort of, all of my research now, I say, it has this exercise base. So I add physical therapy, which is what I do, with a bit of exercise with it for fitness as well. So building off of ACE and also trying to tailor programs for some of the different tumor groups. So I'll just share 2 trials, one that's completed and one that's ongoing. So the first one we call the DREAM trial. And this trial was done by, as Hannah said, graduate students do all the work. Mona Alanazi, who finished her PhD this past spring. And so this was a study looking at 60 women with breast cancer-related lymphedema. And we wanted to look at combining the physical therapy, which is kind of what I do, with resistance exercise training. So if you don't know what lymphedema is, it's a swelling that occurs in the breast, the chest wall, and the arm on the side of the breast cancer. And it's due to having lymph nodes removed or radiation treatment to that region that damages the lymphatic system locally. And so in the clinical setting and physical therapy, we will do compression therapy to try to reduce that swelling. At the time when we started this, resistance exercise training was recommended for women with breast cancer-related lymphedema. It would improve their fitness, their functioning, and symptoms, but it had was seen to have a neutral impact on the lymphedema, meaning it wouldn't make the swelling better, but it wouldn't make it worse. We decided, what if we combine these treatments? So what if we do the compression therapy with the resistance exercise training? What will we see? We did this program, again, delivered in person and virtually to improve accessibility. We also were able to add a novel MRI component. So normally you can see in the picture down here, we usually measure the arm on the outside. That tells us the size of the arm, but doesn't really tell us the composition of the tissue. So I'll see if I can get my mouse over here. I'll just go over here. So what I'm going to show you is some pictures. Maybe it'll come. There we go. Okay. Can you see that? So this is one participant in the study. So just to show you, this is the arm on the opposite side to the breast cancer. So it doesn't have any swelling. This is the arm right here with the swelling. And then you can see in this little compartment, the subcutaneous compartment there, in the green is the fluid. So that's that excess fluid that we would see in the arm. This is after the 12 weeks of the exercise and compression. So there's the unaffected arm. Again, not much change there. But then you can see in the affected arm, can you see how there's far less of the green? So far less fluid in that arm. So we were able to see with this individual, increase their muscle strength, their muscle mass, reduce their fluid content in the limb. So having this imaging has really helped us to also see how exercise may affect the lymphedema. And the last study I'm going to talk about today is what we call Control for Life. So this is a study for individuals with prostate cancer who've undergone surgery for the prostate cancer. And we call it the Continence, Sexual and Metabolic Health to promote prostate cancer wellness for life. And here what we're trying to do is, again, physical therapy, my background, looking at pelvic health. So a lot of times we will teach pelvic floor muscle training to individuals with prostate cancer to help them with the incontinence or the urinary leakage that happens after surgery. It takes these men about a year to gain their continence back. So for those muscles to learn how to control so they don't have leakage. What we wanted to do with this study was to combine that pelvic health with exercise for fitness. For these men, when they are having problems with incontinence, they often don't move that much because when they move more, they leak more. And so it becomes a barrier to exercise and they become sedentary in that year that they're kind of recovering from the surgery. So again, combining this, and what we were able to do as well is using imaging. And so you can see down in the far right-hand corner, we can actually image the pelvic floor muscles and see how well they're doing with that training of that exercise, and how it's recovering over time. And then we slowly introduce more exercise for fitness to see if we can get these gentlemen moving earlier and doing more fitness through that year of recovery. So in summary, exercise can be safely and effectively implemented for individuals undergoing and recovering from cancer treatment. Clinical exercise physiologists, just critical in assessing risk, tailoring programs, and ensuring safety. A real key part of our team with ACE. Having multiple locations and delivery formats really helps to improve access so we can get more people to exercise programming. And ACE really provides a strong foundation for ongoing initiatives. I think as we've learned more and more by implementing ACE, we've come up with some unique ideas in terms of interdisciplinary interventions such as physical therapy along with exercise. And we have many partners in our ACE program and many funders. So thank you.